Next slide, please. Here.
All right, good morning, everybody. Thank you for joining us in today's session. The first slide, we're kind of just going to go over the objectives for our PowerPoint today. And we also wanted to leave a good chunk of time for lots of questions and clarifications on some of the objectives that we're going to be reviewing. So we're going to go right into it. And the first one talks about the objectives. So participants today will learn basic strategies for engaging with the mentally ill folks. Helping them to accept treatment or seek treatment. It'll cover basics of the triaging with homeless individuals, crisis intervention for mental health, learn how to initiate emergency MH evaluations, how to initiate guardianship, and about working with a mental health provider. These are not linear in the application, but rather a box of tools to help be applied to each case. They're all different case by case. For each individual's treatment plans are created based on sort of the vulnerabilities that we're looking at when working with each person on the street.
Good morning. Thank you for taking the time to participate in this discussion. We want to talk about our process for creating help in the community. As you can see from the picture in this slide, there's a Dr. Koyanagi engaged with individual in the community. So using an outreach approach, we observe what is happening with folks living in the community with mental illness. We try to go out and engage a minimum of 3 times per week with folks to be very intentional and be very consistent with what we're doing. It allows us the ability to triage, to make quality assessments depending on whether or not the individual needs medical care, psychiatric care, maybe they need substance abuse treatment, maybe they just need a friend or somebody to listen to what's going on. A lot of times by coming out repeatedly, we're able to build the rapport and establish a relationship which will allow us to do an intake or link the individual to quality supportive services along with medications. Again, like Nisha was saying, none of this is linear. We can pick this up at any point. We can provide services at the first encounter. We can provide services in the middle. None of this is, a 1, 2, 3 process. It's actually something that just needs to be done. It should happen organically with the individual in the community. Next slide, please.
Okay. Engagement, establishing a relationship. These are just the core things that we highlighted that are important when meeting people out on the streets. How to engage. So the first one we talked about is being warm and welcoming, customer service oriented. People come in many different forms, and some of them are really psychotic. Others are able to have a very good linear conversation. But whatever the case is, however they present, whatever challenges they have at that current moment, we really approach individuals at very non-judgmental, very calm, collective, and listening to them and asking questions. Sometimes when people are severely psychotic, their messages are all over the place, their communication is very scattered, and it's an opportunity for us to build rapport. It's an opportunity for us to listen to that message and try to understand the trauma that someone's been through and try to understand how to provide the appropriate intervention and services needed for somebody. Focus on hearing the story and identifying the barriers. We have many people, we have veterans out there, we have families out there, single men and women. And so identifying the key stories and the things that they've been through will help us create a good treatment plan to support individuals. And like I said earlier, there's no one factual way that will work for everybody. I've been here for almost 10 years. And the exciting part of our job is we get to create opportunities and treatment plans that it might be different from the last person. It might be more intense or less intense. It just depends on the situation we're dealing with. Meet and express need with when possible. And most of all, be yourself. People can tell when you're being genuine, and people can tell when you're nervous. For me and Justin, we've been doing this for many years, and it's like sitting next to a family member. We just sit right next to them, we eat with them, we talk stories with them, and we really try to get to know who they are and try to look past the orientation of somebody being disheveled or dressed inappropriately or acting psychotic. We give them the benefit of the doubt that, they're a real person, and some of these people come with a lifetime of experience of being professionals themselves, and so it's just a real opportunity to get to know people out there. Next slide.
Again, we'll talk a little bit about assessment and triage, and it's really critical to utilize our primary skill of visual assessment. Oftentimes, that's all we're going to get when we walk up on an individual in the community and they need mental health treatment or they need medical care. Oftentimes, the wounds are covered. People don't walk up to us and go, "Hey, I have a mental illness." So we have to visually see what is happening. Information for an assessment can come from what the patient is doing. Maybe the patient is, in a large group and might be trying to purchase or buy drugs. You never really know. So it's really important, like Nisha was talking about listening to the individual. An assessment, a good assessment will help us determine the next steps. We don't want to give somebody substance abuse treatment if they're not an active addict. That would be a completely inappropriate referral for us. So we want to do really good assessments. We also want to take the time to engage in HMIS, the Homeless Management Information System, to find out if there's pre-existing enrollments in the system with other providers. Maybe there's a case manager. Maybe the individual comes from North Shore Mental Health Case Management. Knowing these things can help expedite the process. It also takes a little bit of the burden off of the team and having to be the sole responsible individual party for that particular individual. I often don't ask the question, "Are you homeless?" I ask people, "Would you like help finding shelter or housing?" I just assume that an individual is not going to come up to me and say, "Hey, I'm homeless, I need help." So by offering to help them and just kind of stepping in and saying, "Hey, we're willing to help," it kind of lowers the barrier, makes it more easier for the person to reach back to us and want to accept the help.
If you should find out that somebody does have a service provider that they're linked with, what do you do?
I call them. One of the things I do is I call the provider and I try to let them know that, I understand that there's some HIPAA stuff there, but we call them and just say, "Hey, listen, if you're looking for this particular individual, they're here in the community. If you'd like to reach back to us, here's my number." We never really fully assume that the client is with that agency. We reach out to them and say, "This is where this individual is at." We allow that particular provider to make a conscious decision as to whether or not they're going to engage with us and link with the consumer. Again, HMIS is valuable in this situation for historical data. As we all know, when we talk with folks in the community, what was your last medication? When was the last time you seen a provider? It's very hard to get really critical, good information. So it's very important to link with HMIS. Next slide.
Oh, for a second, Justin, there's a question here about what's the timeline for someone health help?
What's the timeline for?
I think for getting, what is the timeline for getting someone some mental health treatment, mental health help?
I think the answer to that question varies on the individual's willingness to accept services. Mm-hmm. There's times where we walk up and we meet a person, "Hi, hello, and here's a bag of hamburgers and a soda. Here's your medications." And they're like, "Yeah, great, I'll take it." But other times it could take upwards of 2 years. We've worked with a few individuals for maybe like the last 4 or 5 years, and we have very little movement with them. Mm-hmm. Unfortunately, we have to utilize, and we'll get into this later on in the conversation about using assisted community treatment petitions, guardianship, and other methods to achieve providing mental health services for those that are unwilling to receive them. But the straightforward answer is we're able to provide psychiatric and mental health treatment to folks immediately if they're willing to accept it.
Thanks, Justin. Another question came in about what HMIS is. HMIS is the Homeless Management of Information System, and that is the system, the database that all of us, we record our encounters with them, but you can also look up, if somebody has had.
All right, mental health crisis. These are just some of the things we see out there on the streets, and different levels of crisis and different ways we can interact with people or call EMS or HPD. So the first one here on our slide is assessing when somebody has suicidal ideations or they're acting out, they want to harm themselves or others in the community. This is a one good indicator for me and Justin to sort of step in and provide that mental health intervention. The second one will be completing acts of harm towards others, and then refusing medical treatment. So as you can see our gnarly picture on our slide, this is just a type of wound that we see out there on the streets. And of course it ranges. It can be, many different types of wounds, cellulitis, staph infection, just a lot of different things going on with our consumers out on the streets. Or it can be more medical, maybe a diabetic shock or something more critical where EMS has to step in. When people refuse medical treatment and outreach workers clearly identify that it's a situation that we must step into and provide that intervention, then we do so by many different routes. Maybe somebody's unresponsive and they're shallow breathing. So again, if somebody's in diabetic shock, we have people that are catatonic and they won't speak to us, and so we kind of have to play into bringing our medical director out with us and making a good, clear assessment about what's really going on with somebody, and that oftentimes means we have to, wake people up and make sure that they're okay and they're alive and they're breathing. And there's been many instances where we've had to stop the outreach route for the day and kind of attend to a medical crisis at that moment, and we'll follow them to the hospital or whatever it may be to kind of stabilize somebody. We have those who are having substance abuse psychosis, so they're acting out, right? They're dually diagnosed or they're polysubstance. We have individuals who their addiction is anything and everything they can get their hands on, and it's really critical for us to assess what's really going on with somebody. What are they using? What's their addiction? Based on the addiction, that's the intervention we provide. Sometimes it's addiction, alcohol withdrawal. Sometimes people are having seizures. Different ways of interacting with people who have for the array of different addictions, and paying attention to those, which ideally these are the folks that we would do the MH calls on, but these are people with diminished capacity. So obviously we would need time to build that relationship and to build the assessment and to know what is diminished capacity. When do we deem somebody to have the inability to sort of function on their own, provide, take care of themselves? And when is it that we have to step in to sort of say, okay, enough is enough, basically. We've assessed you for X amount of time, and it's very clear and evident that you need us to basically advocate for you and to push you forward, because the likely chances of some of these folks surviving on the streets for months, sometimes even weeks, we have to make that call, and it's a very critical piece of our job. So next slide.
Evaluating the need for legal intervention for treatment. A lot of times you can see the gnarly wounds here, so when do we step in and make that call to say, hey, we're not going to walk away. We're not going to let the situation continue the way it is. And you can tell from these wounds that this has been an ongoing medical condition for this particular individual. So these are things that we're looking for. Is there a degree of cognitive impairment? Is the cognitive impairment blocking the individual from accepting mental health treatment or even medical treatment? We have to make that kind of assessment. Is the cause or origin of the cognitive dysfunction? Is that the basic barrier for this individual receiving mental health or even medical treatment? If it is, we feel it's necessary to potentially call in the oral ex parte for an individual. The other times is when an individual is putting themselves or the community at high risk. So walking into traffic at once, yelling at people. We had one gentleman in Waikiki who just sits on a bench and yells profanities at people walking by. People have tried to attack him, and we often find this individual in the community with a black eye or a swollen lip. Again, this is based on the cognitive impairment. The individual, unfortunately, is not able to live in the community safely on his own. So we have to step in and make some kind of decision for the individual. Obviously, we don't do this like I am not a certified licensed professional, so I wouldn't normally do this on my own. I would reach out to Vinnesha or Dr. Koyanagi, Connie Mitchell, Jerry Coffey, or maybe one of our other providers at one of the other facilities, Dr. Lum and such. So again, when we're evaluating the people for legal intervention, it's not something that is taken lightly. There's actually a team of us that get together and discuss each one of these cases individually. There are times when, Dr. Koyanagi and Vinnesha and I are out doing an outreach when we decide on the spot that we were going to go for it, simply because the person is in such a bad state that they need immediate medical care or immediate mental health services. In those moments, we would use the family court, and I'm sure we're going to get into it here in the next couple slides about the family court and that system. But for folks that don't get the oral ex parte, we're going to go down the guardianship route. So next slide.
Is there questions, Connie?
Yeah.
I wanted to comment that, for a person who has such wounds, and you've encountered some people who have all kinds of explanations about how they're taking care of themselves, right? Like,
Yes.
and can you share some of those kinds of examples?
So we've had one lady who covers her wounds in newspaper and says that they're covered and taken care of, and she puts baby powder on them. I guess baby powders keep the mites off of the wound, and the mites are the ones that are causing the wounds. And that's just the cognitive impairment for this particular individual that I'm talking about. She believes that mites are attacking her body, and that the wound never gets better. It actually just continues to get bigger. And so those are some of the ways I've watched an individual pour a Coke over their wounds. Again, I don't understand. Maybe sugar attracts ants and ants take away the infection. We're not really sure how that works, but there are all kinds of different ideas that come up. I've watched a man with a broken shoulder. The collarbone sticks out of his shoulder. Literally, the bone is sticking out of his shoulder, exposed, and he refuses medical care. And this is something very similar, very simple, like fixing his collar. It could give him such a greater quality of life, a lot more range and movement in his arm. And it's just really sad to watch. But at the same time, by being present for that individual, we're able to help facilitate some medical care. We have a nurse that comes in with us and goes out and helps. And so she's really good about, hey, let me check it out. Let me look at it. One thing that's important about wounds is not to open them up unless you can cover them. If we open them up, we have to have the ability to cover that wound. It's critical. That answer the question?
Yeah, thank you. So another question, how substance abuse affects the mental health of somebody. And, it certainly doesn't, just for your information, everybody, I am a clinical nurse specialist, psychiatric. And so, when someone has a serious substance abuse problem, the presentation can look very much like this. Somebody who's been a meth addict for a long time can look like they have schizophrenia. So it really does require some careful assessment and a lot digging around for the history of that person as well and getting some records.
Connie, just to follow up on that statement about substance abuse appearing to look like schizophrenia, what we found is that if people come up to us and they're engaging us, they're like asking us questions, a lot of times it's not schizophrenia, it's substance abuse. People who have real schizophrenia and have this, they're going to be kind of withdrawn. They're not going to want to engage in the conversation with us. There's going to be a paranoid aspect to it. Folks that are high on drugs and experience psychosis are like, hey, can you buy me a soda? They come up and they're asking. So it's a different kind of, so in our experience, we found that folks that are asking a lot of questions and very talkative probably have a substance-induced psychosis versus the schizophrenia with paranoid delusions.
So there's another question about what is a safe way to approach someone with mental illness? I'm going to advance the slide to the next one.
Food is always a great approach.
There's many different ways to approach individuals. We kind of don't just go straight into interacting with somebody. We do it very carefully. And actually, I think that's the thing that works best with me and Justin is it might be better with a female to approach somebody. It might be better for a male to approach somebody. But we like to assess to see how dangerous they are, first of all. We want to make sure that they're safe, we're safe, and that there's not going to be any incidents happening. But we do a lot of harm reduction methods. As little as, do you need a pair of slippers? Can I buy you a nice blouse at Walmart? Can we go get some lunch to eat? So there's different ways of engaging. And we just kind of play it by ear. We kind of see like, okay, this is gonna work. You know what, Nisha, you go try, or Justin, you go in for this one. But you want to make a good assessment about the person before you go straight in. The next slide talks about algorithm for possible interventions. And this one talks about the different interventions that we provide when we're out there on the streets. And so voluntary treatment through assertive outreach engagement. The next one is 911 police and arrest. Emergency evaluation for an MH request. An oral ex parte for emergency inpatient evaluation and treatment for an MH2. The next one is guardianship. Then we have assisted community outpatient treatment, which is our ACT, and we'll go into a little bit more details on that. And then we have an MH4 civil inpatient commitment for hospitalization. And the last one, an inpatient order to treat, OTT. So there's so many different ways where we can sort of jump in and provide the critical needs for somebody. Obviously, it's almost like a triaging effort where you have to look at how critical the person's needs are. There's different barriers, different interventions for each one. And I think the neat thing about doing this for the last few years is that 911, EMS, they all know us very well. And we've been able to build relationships with even Queens Hospital and Castle Hospital. And those relationships actually carry us through all of these interventions without having those contacts and being able to communicate with each provider. You have to be able to have a good streamline or like a good process, because through the learning experience, if one thing is not put in place or you don't communicate your efforts with everybody, the ball can be easily dropped. And so when we're looking at the different types of interventions here, you just want to keep in mind that some may work for individuals and others may not. But the thing that's really neat about, our efforts is we're very creative. Sometimes we have to mix one or two together. Sometimes we have to go 100% on an oral ex parte, and other times we have a guardianship, a parent or a family member that steps up to help us. So these are just some of the interventions that we use.
So someone has asked whether this program is on the Big Island also. I just want to say that the legal interventions are available to anyone. But as far as the program itself, I think there are mental health case management programs that probably do some of them. We would have to kind of ask, whether they are engaged in some of this. We're specifically able to do this because we have a focuses on mental health outreach for people who have mental health.
All right, this next slide covers initiating emergency MH evaluation. Coordination with our medical director to provide historical information on possible high utilization and to provide clinical support for emergency site care. So what this really means in plain and simple words is we're very fortunate and blessed to have a Dr. Kuranagi, who actually comes out with us, who's also our medical director. And we're able to gain insight from him about someone's utilization. Maybe he knows them from the hospital. And it's not only Dr. K. We have a partnership and part-time Qs that help us to determine what is someone's level of need, whether it's medical, mental, or substance. That's good input for us when we're doing the MH evaluation, because all that information is going to be used to sort of build a case to support the request for us to really give them the service they need, even if they're not consenting to it. The second one is linkage, collaborate with CCS, CBCM, or ICM case managers if they exist. Those are just fancy acronyms for some of the very robust case management programs that we have here at IHS. And this goes back to, how do you check if someone has case management? How do you talk to people who know them? And the neat thing about, service providers in this day is that we all work very closely. And the information you need from one organization is actually going to be put towards your efforts because you can add them into your documentation. You can look, okay, what is someone's history? What if somebody has HIV or AIDS, or what if somebody has underlying cancer? So all of the information that you can gather from previous case management is going to help you to build that case for your MH. The next one is proceed with calling family court to request an oral ex parte. And this one is also a critical one because say we're out there on the streets and someone needs help, they need medical attention, they need mental health intervention. It's now an opportunity for me to gather this information, make a clear assessment about what am I seeing, what's making this person vulnerable, what's making them dangerous, what makes me and my partner say, hey, if we don't stop and we don't call this in, something's going to happen to this individual. And that's when I call the family court. I give them all the information. The family court judge is often going to ask us, like, why are you calling? What's so important? What's so vulnerable? So I have to have those details down very strategically and very specific. I take a look at the wounds. I had one individual where he had literally maggots coming out of his foot and feces dripping down his leg. And I'm sorry if that's really detailed, but these are the things that the family court judge, they really look for those type of details because it's a sticky process. And we'll get a little bit more into the barriers that we face when trying to go through this. If granted, wait till HPD arrives. So HPD will then come on. They'll also help us with de-escalating. We've been collaborating a lot with HPD efforts to teach them what's the best way to interact with homeless people. And I think that's been a good support for our team. Typically back in the days, HPD would just show up, throw them in cuffs, and they would be on their way to cell block or wherever it is. But now HPD shows up in there saying, okay, Nisha and Justin, what do you need from us? Do you want us to put them in cuffs, or do you want us to nicely put them in the back of a non-marked car and just transport them? So we have that collaborative communication between HPD, which really helps us build that trust with people, because in the past, when people seen officers show up, they already know they're in trouble. And now it becomes an opportunity for us to include the community and include the HPD officers in the person's treatment, because say we're done with today, right? The day goes by. HPD officers are going to see this individual every single day. And now this particular HPD unit is going to know, hey, I know you. You've been working with Justin for 2 years now. Have you taken your meds? Have you taken a shower today? So that's just a neat part of working with HPD. The next one is facilitating transportation, which I talked about earlier. We can decide if it's going to be against their will. Obviously, HPD has to handcuff them and do their due diligence in making sure transportation is completed. Other times, me and Justin will put them in our car and we'll take them. If it's more medical emergency, EMS does show up, and EMS does provide that transportation for us as well. So there's different options and way of doing that. The oral ex parte, outside of us calling, that exact communication has to be documented on an oral ex parte form, which needs to be submitted within the next 24 hours. It's very critical that we drop off the paperwork to the family court within that time frame.
Can you, in the photograph that we have here, you can see an individual being arrested by HPD, and the case manager is standing there with the assisted community treatment paperwork in his hand, ready to give it to HPD. Again, when we do these things, these are very coordinated efforts on our behalf and for the client. We want to make sure that a person stays safe. And fortunately for us, the HPD officer that showed up in this particular picture knew what we and what was going on. It was a very smooth process once they showed up. It took less than 5 minutes. There was no conflict. The individual got into the car. HPD transported the individual to the hospital. It's important for us to follow up in the hospital. We need to go to the hospital, one of us, either the case manager, the outreach worker, somebody needs to go to the hospital and be there to help when the individual gets in, and let them know that we are on the team to help with the discharge. You know, once a person goes to the hospital, that's kind of the easy part. We're really focused on the discharge and what's going to happen when they leave the hospital, because at that point, the individual can get lost in the community again, can get high, get loaded, get injured. And so we really want to try, if we're going to medicate folks through this oral ex parte process or through the emergency MH, we want to be there on the end so we can make sure the individual has a better quality of life when they come out of the hospital. Next slide.
So I just want to interrupt for 1 second here. Wanted to remind everybody to go to the conference website, particularly if you need or want CEUs, continuing education units. So that's where you can get them. You would need to complete the evaluation. I also, sorry, I'm going to leave you all in the hands of Flo. I'll be taking over the hosting of this session because I have to go host another session. But thank you.
Thank you, Connie. Potential barriers and challenges. Welcome, Flo. Potential barriers and challenges. A person refuses to cooperate, they walk away. Person can be combative, acting out, running into traffic. An MH can be denied, not enough evidence. All these are potential barriers for us. The real barriers that we're looking for, though, are barriers that will affect the individual's rights or ability to accept mental health treatment. When a person is combative, we recommend coming back to provide services at a time when it's safe to provide them. Prior to initiating an MH, make sure there is time. You know, at the longest, it takes about 4 hours for an oral ex parte to be from beginning to end. It takes about 4 hours, the whole process. It's really important that if you're going to initiate something, that you're able to finish it all the way through. And so we have to sometimes take the time to think it through and, okay, what are we going to do? It's, you know, obviously, if the situation warrants, we will stay as late as it takes to get it done. But it's something that's going to take a little bit of time. So if you're going to initiate it, be prepared to spend some time in it. Speak with HPD about the desired location for the client to go. You know, like Nisha was talking about, we have the option in many cases to send an individual to Castle Medical Center or to send them to Queens or to send them where we know that the most resources are going to be available for them. So that's some of our goals when we're doing these. You know, we need to think about the outcome. How is it going to, you know, are medications going to be administered? If medications are going to be administered, if we administer medications in the community without using the MH process, if we administer medications, is there a safe place for the individual to fall asleep if medications cause them to be drowsy? You know, so we offer shelter before we would just medicate somebody. We try to get them to accept some place where medications can be administered safely. Obviously, we have a few individuals in the community who take medications right in the community. They're more than happy to do it there. They refuse to go to shelter. Paranoid delusions kind of make it difficult for them to live in a population or in close confined quarters with other people. You know, I keep talking about focusing on the end. You know, I normally won't initiate an MH or oral ex parte or any of these kind of high-end interventions if I don't have a plan or a place to put an individual. Last thing I want to do is put a person in Castle for 7 days and then not have a bed for them at Tutu Birds or Kurds or some kind of facility where the individual will have a safe place to go. So the other thing is be prepared for the barriers to be coming up as you're working through the process. We plan these things out. They take lots of planning. They're very coordinated, and suddenly, you know, things go off the rail. And so you have to be prepared to move with the flow of what's happening inside of the process that you're doing. If we said that this was a linear process, 1, 2, 3, it would be really easy. Everyone would be doing it. But unfortunately, it takes a lot of time. They're very coordinated, and even the best planning does not prepare you for what individuals will do in the community. So we just try to roll with it. Oftentimes we'll separate, you know, Nisha will be following in a car and I'm running down the road on a sidewalk trying to follow the individual into the community. You have to be prepared to do these kinds of things separately. And so you just kind of got to roll with it.
I just want to add to I want to emphasize the importance of communication and being very consistent and assertive when you're advocating for individuals, because depending on who interacts with this person, HPD, you might get an officer that works very well with you, and then it might be a rookie who doesn't really know what's going on. Um, Even when you go to the hospital, depending on the type of social worker you're working with, they might not feel comfortable with administering meds or taking what is called an act petition or guardianship papers, because oftentimes the first question they're going to ask you is, hey, are we violating their rights? Are we practicing within the scope of our professionalism to do this? And so you have to be prepared. You have to be educated about what's your goal, what's your end plan, what kind of. And I think the other thing that helps is when you're talking to the cops or EMS or social workers and doctors, they want to know, what are you doing? Because lots of people have expectations about what should happen to people who come through the ER system, but not very many provide a plan. And I think that's what people appreciate the most, is when you can say, hey, I understand this is new for you. I understand this is not normal practice and routine, but guess what? If you can help me medicate this person, I have a shelter bed for them. I have housing. I've had people that had housing already. They just needed to be stabilized. So there comes a lot of communicating your efforts and being very assertive with some people. Some people are very sensitive, and others, if you just take the time to educate them on the process, they'll let up and they'll work with you, and it'll be so much easier. But like Justin was saying, you have to be there from A through Z to support and to advocate on the goals for your client. Next slide.
I have a question, Caitlin. Says, how has the pandemic affected the process of obtaining an oral ex parte?
I think it's actually helped. I think it's actually helped the process for us, because we're able to, it makes things more apparent about what's going on. Where we've had trouble is with the assisted community treatment, because it is a legal process in front of the family court. It requires going into the courthouse. And because the family courts have had to change the way that they're doing business, to video conferencing and all that kind of stuff, that has been the barrier. But other than that, the oral ex parte process is very easy. It's still going on. You can see in the picture that's being presented now that there are roughly 6 officers around one gentleman. This is, there are 2 CIT, crisis intervention officers present in the picture. The reason that there's so many officers around this gentleman is he's holding a knife around on a string around his neck. And so it's there, and they were worried that he was going to take the knife off. And the last thing this gentleman said is he took the knife off and he threw it at me and called me a liar. And then HPD kind of moved in, and they just kind of brought it down to, and they were able to de-escalate the situation. The individual was able to get access to treatment. He was hospitalized, medicated, and on and on and on. So yeah. That answer the question?
Thank you. Yes. Another question was, what parts of the island do you go to?
Technically, we work East Honolulu. So basically from Turtle Bay to the airport. But I'm willing, and we are willing, to work with folks that have folks in other areas of the island that need assistance. We're willing to come in and offer even just to kind of co-facilitate this whole process with others. If that's what's needed, we're willing to provide some kind of, just basically coordination with an agency or even a provider that wants to do stuff like this. We're willing to, however you need to do it, we're willing to do it.
Thank you.
Next slide. Guardianship. So I often recommend guardianship for folks that you can't get the oral ex parte on. If you can demonstrate self-neglect in calling Adult Protective Services and asking them for assistance with an with a guardianship is a perfectly good alternate solution. It takes a little bit more time. It can take up to 6 months. It's not going to be an immediate fix. The number is 832-5115. I often recommend calling the intake person and asking them, hey, I got the situation. What do you think? They'll ask some questions. There's a little bit of give and take. And then they either decide to take the case or not. Even if when they do decide to take the case, it is our responsibility to go onto the APS website grab the information from there, print out the paper, we fill out the paperwork, and we resubmit it back. Then they send somebody out. It's important, if you do go the guardianship route, that we make ourselves available to help locate the individual for a guardian that is coming out to locate a homeless individual. Obviously, the guardians that are assigned to these cases are not going to have the ability to know where the individual is always at or find them. So it's important that we collaborate with APS as providers, and we're asking them to help us with these kinds of things. One of the cases that we had of guardianship resulted in being able to provide medications to an individual who was refusing them through Adult Protective Services. So it was a very good referral to APS. Again, just make yourself available to the APS team when they need our help. Next slide.
Sure, I have a question that came in. It says, is the guardianship a temporary one or an unlimited one?
It's really up to the judge, and each case is individualized. So if we can present that this is going to be an ongoing issue, the guardianship can be forever. If it's going to be something like, maybe stabilized, guardianship could be for a time period. It's really up to the court, and the judges make those decisions all on their own. We can advocate, obviously we would advocate for the most help we can get for the individual.
I will say personally, like the guardianship process, it's lengthy and it's long, but having a guardianship document in your hand as a provider, it's so much more easier than trying to go for an oral ex parte, because you don't have to call the judge. You don't have to prove they're vulnerable. What you're doing is you're basically taking the person to the hospital, right? And you're telling the social workers, hey, this person has a guardian. They're actually requesting medications ASAP. We have the medications in our hand. We have the document in our hand. Please administer. So it's a little bit easier process than having to call the judge and go through the whole formal process. I just wanted to add that.
It's important when we're talking about medications that any medications that we take to the ER for a patient are unopened and has the patient's name on them. Otherwise, the ERs will not take them. They'll just know. That is immediately what happens. And so it helps. And so that's one of the things that we've learned over the years, is that if we have the meds in our hands, we take them in and have the patients, the ER is willing to work with us and help us get those medications to the individual.
So this last slide is pretty much things that we've covered in previous slides, but we're going to kind of open it up for questions, Flo, unless you have more stuff.
Okay, yeah, I was just gonna tell you guys got about 15 minutes left, so maybe we can open up the questions. Or
Yeah.
I'm gonna finish your slides first though, Vinnesha.
So I think we're going to skip this. We're going to open up to questions. But the one thing I did want to highlight is the very last slide, Flo, where there's links. So if you guys want to watch a documentary and kind of look at the work hands-on in the streets, basically. You're watching me and Justin interact with people who are severely mentally ill and need that type of assistance. One more slide down. There you go. So that's just for reference in case you folks want to watch. Like Hawaii News Now did a documentary with us. I'm sure most of you have seen it. If not, go ahead and check it out. But we would like to open the last part of this for questions.
I see there's a question on here that says, how do you treat someone who doesn't give consent? And so oftentimes it works in our favor when an individual doesn't want to give consent to us, because it gives us, on her screen.
Oh.
It gives us the opportunity to work with them, and we can avoid some of the HIPAA stuff. Obviously, it's not our client if they're not giving us consent to work with them and they don't want. But what we found is by utilizing incentives and engaging the person repeatedly through intensive outreach, that eventually that resistance to services comes down, the individual opens up, and we are able to provide services to them freely. I can't see.
Hey, Flo, we can't see the question, so do you mind giving us some?
Oh, sure. I'm sorry about that. A question that came in is, the Leeward Coast has a high population of mentally ill homeless. Are there any groups that advocate for them?
There are plenty of groups out on the west side that are working. Cal West Oahu, Waianae Civic Center, they have teams out there. There's Waianae Coast Comprehensive Healthcare. They have psychiatrists out there. Maybe the approach is just a little bit different, or maybe what we've been doing is a little bit different, but the resources are there in each of those communities. If an assessment was done on resources and where we can get psychiatric care, Waianae has all those resources in the West Side.
Okay, let's see here. Sorry. Another question.
I see a question here. It says, isn't there some way to get enough permanent housing and case management for mentally ill versus providing spot treatment on the street or short-term interventions? And the answer to that is yes. But what we found is that it's very difficult to offer somebody housing without mental health treatment prior. So it'd be kind of irresponsible for us to put somebody into housing with paranoid schizophrenia without medications, and not having some kind of supervision in place. We'd be concerned about them maybe burning down the house. Are they able to take care of their basic needs, wash their clothes? Are they able to not be disruptive to the neighbors or neighboring, and all these things come into play. And so one thing that we want to do is, if we're going to put a person into permanent housing, we want to make sure that that person's going to be able to live in there safely. So we would try to stabilize an individual at like one of the less restrictive places, like one of the shelters, one of the Two Birds houses. We would monitor them to see if they're able to live independent. If they're able to be independent, then we would definitely move them into a permanent place.
I also wanted to add that, Justin is talking about, instances where we find other types of placements, but I want to make it clear that we do have the capacity to house people. We use our housing first model to put people into housing. And the whole idea is housing first, treatment second. And so if we can find a treatment plan where we can house somebody and put in in-home health services, put in family members, put in Meals on Wheels and care coordinators, we'll layer all the resources. So yes, it is very much possible to go either way. Justin's way, the less where we're putting them in the community, or the other way where they're more independent. Very much possible.
Situational. Next question.
It says here, who writes the social report for the legal guardianship? I've written many for legal guardianship, and there is specific information that needs to be put in the MD report and the social summary. So I'm trying to understand who does that.
Licensed clinical social worker, a Q, doctor, Dr. Koyanagi, Jerry Coffey, Vinnesha Bertola. These are just some of the people that write them for us, but I'm sure that like Care Hawaii, North Shore Mental Health, they have all the resources. All you would need is to have a licensed professional to write it up. It's not that hard.
I have a question here. It says, when someone tells you you're violating their rights, but they are harm to self and others, what do you guys do?
Well, we just explain the truth. We're worried about the risk to their self. We're worried they're going to hurt themselves. And we just ask them to please understand that, please communicate to me how you can continue to live safely in the community, please. And so again, we redirect the conversation back to the individual. And oftentimes it helps us to build, basically a history that the individual lacks capacity to live safely.
I want to also say too, like sometimes that's not even a conversation that you can entertain until the medications are safely in. And we've done it to where the medications, and then 24, 48 hours, they're actually like a lot less aggressive and they're willing to listen to you. So me and Justin will go back to the hospital and we're like, okay, you ready to talk? And they're like, yes, I'm ready. They put down that wall, they're less agitated. So it's about, being patient and letting the medication do its work.
Okay. And after an individual is housed, how do we get mental health services to cooperate?
Oh yeah, I mean, there's so many different ways to do that. We have service coordinators. We have in-home, the health plans will jump in, whether, people know it or not. Ohana and like all health plan people, they're willing to jump in. They just got to know when and where and how. So it just means that we have to communicate the needs of somebody on all levels and try to triage that and help to kind of intertwine that into their housing.
Behavioral health services are critical here. Getting an assigned case manager and a community provider that are willing to go into that home and see that individual in housing is critical. If you can do it in home, it's much more productive, it lasts longer, and the relationships stick.
Can I just also say one thing? I know you guys hear us talking about medications, and medications, but medications is not the end all be all. And quite frankly, we've had a chunk of people who have taken medication, and that's not enough for the treatment. That's not enough for them to get better. So it's important for us to do a lot of behavioral coaching, a lot of motivation. People have lost touch of reality for 15 years. It's about re-engaging them into the community and finding out what makes them happy, what makes them uncomfortable. It's as simple as your basic level skills for how do you work a microwave? Where do you use a restroom? So we talk about medications a lot, but the bigger end of this is being consistent with somebody and building that rapport and communicating with them every single day.
Next question is, are there shelter resources to help these individuals?
Yes, yes. Shelters are not going to, they're not going to discriminate against folks that come in with mental illness. If they do, then yeah, that's outside this conversation.
Yeah, it's an open door policy here at IGES. There's no wrong door. We put people at HMO or one of our respite houses just to accommodate somebody and make them feel at ease, make them feel comfortable, and then they'll be able to like entertain the idea of going into a shelter or going into a group home. But it's a slow and steady process. So we have the ability to be really creative. And the neat thing with IHS is everybody is hands on deck. So if I highlight one individual in the shelter and I say, hey, so-and-so, he has ADL problems, he can't use the restroom, he will probably scream throughout the day, but listen, he's not dangerous. Don't kick him out. Don't call the cops. So again, it's about communicating and just working together to highlight what are someone's needs.
Next question is the Adult Protective Service. Do we have a 24/7 phone number throughout the day?
No. APS, I think, is like from 8 to 4:30. Sorry.
But you can call Access Line at 832-3100, and that one is an extension of APS. So if someone is at farm, they want to kill themselves or hurt themselves or others, Access Line is another good resource.
You know, we have like 4 minutes, Flo, and I
We
just
do.
want to say thank you. I just want to say thank you to everyone who participated and listened into this presentation. I hope that everyone got something out of it. It means a lot for me to be here to share with you folks, especially the work that we're doing, because it is so personal for me. I just want to say thank you.
Yeah, and same here. You know, we were so nervous coming into this session. I always tell everybody, if you're not homeless, I am nervous. I don't know what to talk about if you're not somebody on the streets, but we really have passion for being out there. And I think if you're interested in this kind of work, you need passion, you need consistency, and you need to be able to kind of advocate. I always tell my workers, go out there like you're advocating and fighting for your mom, dad, brother, and sister.
Yep.
That's what we really do out there.
Awesome. Let's try and fit one more question in. What is the success rate of getting them stable?
105%. I don't think we've been unsuccessful with anyone that we've ever worked with. We've had people pass away in our care, but we still were caring for them. We've had people that are still on the streets today. They're still talking to us, so it's still a success. We're still working through that. We've never failed. That's what I'm going to say. And I don't think that anybody who does any of this work has ever failed. It is a calling for people to be on the streets, providing services to folks, to be willing to engage people, and to be providing some kind of humanity. Yeah, it's a calling.
Awesome. My understanding is that at 11 o'clock, you're just going to cut us off. So I think we'll say our thank yous now.
Okay.
And thank you for joining us. And thank you, Jen, for sharing your experiences with us. I hope everyone gets something out of this. And
Thank you, guys.
everyone, take care.
Mahalo.